Good day and welcome to the second ERAS Society worldwide free webinar on perioperative opioids and ERAS. My name is Dileep Lobo and I'm the chair of the scientific committee of the ERAS Society, and along with Bill Fawcett, I'm the co-organizer of this webinar. We are currently in the midst of a global opioid crisis, and there are more than 100,000 deaths per annum worldwide as a result of opioid misuse. This figure is increasing every year, and the financial costs run into over $150 billion in the US alone. This is spreading to other countries as well, and at the moment, there are more than 1.3 million high-risk opioid users in Europe. In addition, drug companies are targeting sales in low and middle-income countries, and this is likely to fuel the fire further. There is an urgent need for mitigation strategies, and with this in mind, a group of us got together last year and published a consensus statement on the prevention of opioid-related harm in adult surgical patients. This has been published in Anesthesia and is available as a free download. Today's webinar will discuss various aspects of the opioid crisis, and I'm delighted to introduce the speakers, all of whom are authors of the guideline. Sean Dowdy, Jane Quinlan, Nicholas Levy, Pam Macintyre, Felicia Cox, and Ed Mariano will discuss the topics. In addition, we have a distinguished panel for the question and answer session, and this comprises Hans de Boer, Gregg Nelson, and Bill Fawcett. I would encourage the audience to ask questions on the question and answer line, and we will have a robust discussion at the end of the talks. So without further ado, I welcome you all to this webinar and hand over to my co-chair, Bill Fawcett, to introduce the first speaker. Thank you.
Hello, and thank you, Dileep, for that introduction. A warm welcome from me, where we've got about 350 people registered here. Our first speaker is Professor Sean Dowdy, who's a professor of gynae-oncology and also vice chair in the Department of Obstetrics and Gynecology at the Mayo Clinic in Rochester. He's a keen supporter of the ERAS Society, and it's a great pleasure to have him here to talk to us on the seeds of the opioid epidemic.
Good morning, and thank you for the invitation to discuss the seeds of the opioid epidemic. If you want to truly start at the beginning, you'll find that opioids are deeply rooted in human civilization. They're so effective that their properties have been appreciated for thousands of years. Shown here are figurines of the poppy goddess from Greece, and you can see the poppy seed pods adorn her crown. Opioids were also described in Sumerian clay tablets thousands of years earlier. As a gynecologic oncologist, I found it interesting that one of the first references to opioid addiction in modern literature comes from gynecology in the 20th century. The article states that within a few years, many authorities have pointed out the danger of morphinism in women who come under treatment for gynecologic disorders. All control of the will, feelings, and emotions is overcome with it. That sounds like a description of addiction. Certainly, recreational use of opioids has occurred for centuries, but it was popularized in mainstream culture in the 1960s and 70s. Shown here is the iconic photograph of Lou Reed in Houston, Texas, using heroin while singing a song about heroin. But the abusive potential of opioids was denied by the medical community, and addiction from prescription opioids was thought to be rare. This study from the New England Journal of Medicine in 1980 was based on chart review only, and they found that over 25% of their inpatients were dismissed with opioids, itself concerning. But since they found few cases of documented addiction, they assumed it did not occur. And this short letter to the editor was used over and over again for many years to support this dogma that we have little to worry about when it comes to prescription opioids. But in the 1990s and early part of the 21st century, opioid use accelerated and opioid overdoses became common. What changed was the exponential growth in prescription opioids. Prince and Tom Petty are just two examples of individuals being treated for chronic pain who overdosed on prescription opioids. It seems obvious to us now, but it took many years to understand that deaths from opioids correlated directly with opioid sales. This graph ends in 2010, but unfortunately it was only recently that those held responsible for the opioid epidemic were held accountable. Purdue, the makers of OxyContin, were found guilty of misleading marketing, among other things. They're now bankrupt. It is unclear how much money they were actually paid out, and to date, none of the 3 executives who pled guilty have received any jail time. But of course, pharma cannot be held entirely responsible, and physicians, both unwillingly and willingly, contributed to our current predicament. This is one example of many of a surgeon lamenting the part he played, recounting the death of a friend from an overdose. By then, the genie was out of the bottle and the deaths have continued. By 2015, approximately 33,000 Americans died of opioid overdoses each year, and that was in 2015. Fast forward to 2019, more Americans died of opioid overdoses each year than car accidents. And by the time we get to the age of the COVID-19 pandemic, deaths rose further, and even worse, no one is talking about it. Between May of 2019 and June of 2020, 81,000 people died of accidental overdoses, the most in American history. And this vastly underestimates its impact on individuals, families, and communities. And this increase isn't surprising because the pandemic has led to isolation, financial and mental stress, and reduced access to treatment. The problem that continues to grow is fentanyl, which is highly potent and easy to ship in comparison to heroin. Heroin used to be cut with fentanyl. Now what we know as heroin is simply fentanyl cut with heroin. Imports from China and Mexico and the availability of pill presses in the United States has led to the circulation of counterfeit oxycodone that is actually pure fentanyl. And in many cases, just 2 of these pills can be lethal. So in the medical community in the past, there's no question that we overprescribed opioids, but we must also be careful to not overcorrect and underprescribe opioids, as this is extremely important for patients with cancer-related pain, for instance. And I think what we'll talk about later this morning is moving towards appropriate and responsible opioid prescribing. I hope you found this 5-minute introduction useful, and thank you again for the invitation to present today.
Thank you, Sean, for that excellent introduction to today's webinar. We shall now move on to the next talk, which is going to be delivered by Jane Quinlan. Jane is a consultant anesthetist and pain physician from Oxford University Hospitals. Pain is a hobby, or management of pain is a hobby, but her passion is control of grammar, punctuation, and spelling. So without further ado, Jane, the floor is yours to talk about the pathophysiology of postoperative pain.
Well, thank you very much for inviting me to speak today. I'm going to be talking about the physiology of postoperative pain, and I'm going to be talking about the basic science of the pain system and also the pharmacology that we use to modify it. So the pain system is a very important mechanism for identifying damage and harm to us as an organism. The nociceptors, so named from the Latin nocere, which means to harm, detect damage and produce signals which go to the spinal cord and from there up to the brain to give us information about the pain. Now, there are 2 separate pain pathways from the spinal cord to the brain. The lateral pain pathway goes to the somatosensory cortex and the homunculus to tell us about the location, the duration, and the nature of the pain. And it's broadly similar to that for non-threatening stimuli, such as touch and temperature. The second pain pathway, the medial pain pathway, is unique to pain, and it goes to the emotive centers of the brain, the amygdala, insular, anterior cingulate cortex, which tell us that this is unpleasant and we need to protect ourselves. We need to take our hand out of the fire. We need to stop running on our broken leg. And this emotional signaling also links to the hippocampus in the brain, which helps us with memory and learning, so that in future, we remember what caused us pain before and we keep away from fires and preferably keep away from surgeons. There were also descending pathways that go from the brain down to the spinal cord. And these can modulate the activity of the dorsal horn, either amplifying or reducing the pain signaling. Nociceptive pain, also known as acute pain, is an appropriate response to tissue damage after trauma or surgery. An inflammatory soup is released, which contains prostaglandins, kinins, potassium, hydrogen, numerous other ions and mediators that carry on stimulating that nociceptor long after the surgical knife has gone. And this drives the pain messaging. So when we're thinking about treating acute pain, we can use a selection of analgesic drugs that work in different ways on different parts of the pain pathway. And working from the left to the right, we have non-steroidals that block the production of prostaglandins and reduce inflammation. We can use local anesthetics, either as an epidural or in any other type of nerve block, and they just stop the transmission of these pain signals to the spinal cord. Opioids are extremely effective in acute pain, and they work in endogenous opioid receptors in levels 1 and 2 of the spinal cord, also known as substantia gelatinosa, and also on higher regions, the midbrain and the periaqueductal grey in our brain. Tramadol and tapentadol have mixed effects. They work on opioid receptors, but also they enhance descending pathways. It appears that the 5-HT-mediated descending pathway is pro-nociceptive and increases the excitability of the dorsal horn, whereas adrenergic descending pathways are anti-nociceptive and reduce excitability. And it's for this reason that tapentadol is therefore, of the two, a stronger analgesic. Clonidine enhances the alpha adrenergic descending pathways and thus reduces excitability in the dorsal horn, while ketamine acts on NMDA receptors in the spinal cord. NMDA receptors are calcium channels that are normally closed, but with sustained nociceptive input, these calcium channels flip open and calcium pours into the cell, making it much more excitable. Ketamine and magnesium block the NMDA receptors and stop this calcium influx. Then there's paracetamol, whose mode of action is still not entirely clear. We know it acts centrally, and one action might be on the COX-2 and COX-3 enzymes. Interestingly, paracetamol acts best in a low peroxide environment, so acts best centrally, in contrast to non-steroidals that work best in a high peroxide environment in the periphery. A metabolite of paracetamol blocks the uptake of anandamide, which is our endogenous cannabinoid. And another metabolite works on TRPA1 receptors, which are in the spinal cord and are important for the ongoing transduction of pain. So it's really important to note that opioids have a really important role in part of a multimodal analgesic plan for patients with acute pain. The great thing about acute pain is that it resolves. As healing takes place and inflammatory processes settle, nociceptive stimulation decreases and pain reduces. Now, these processes will have definitely stopped by 3 months, unless, of course, there's ongoing inflammation from ongoing infection or from cancer recurrence, for example. But the majority of patients with acute pain have pain that settles within days or weeks after surgery. So what's really important is that when we send patients home with opioids, we make sure that they understand that as that pain settles, they need to reduce the analgesics that they're taking and wean them down. And diagrams like this can be quite useful as a guide for patients to understand how best to reduce their analgesics. And it's important as well that they understand they should be using their strong opioids to improve their function. So just take them as and when needed, such as before physio, for example. The other thing to bear in mind is that the length of time that someone needs to take opioids will depend very much on the operation they've had and also on patient factors. So things like this are a useful guide, but they should be tailored to be specific for that patient. Now, chronic pain is different to acute pain. Chronic pain is pain that lasts more than 3 months and represents a dysfunctional pain system. There is no tissue damage, but pain nerves are sparking spontaneously and sending messages to the brain saying there's pain there. It's an inappropriate response and it's unhelpful. We tell patients that the pain system is a really important fire alarm, and what they have is a faulty fire alarm. So the messages of pain that they're getting feel very genuine, but actually those messages are not telling us anything useful. They're inappropriate and unhelpful. The drug treatment of chronic pain involves anti-epileptic drugs such as gabapentin and pregabalin that reduce the neuronal excitability and ectopic activity of those pain nerves. Also, we can give antidepressants such as amitriptyline and duloxetine that enhance the descending pathways. And over 20 years ago, it was thought that opioids are very helpful in chronic pain. And if they don't work, you just simply increase the dose until the patient's comfortable. We now know that's not true, and it's extremely unhelpful, and they do more harm than good in the majority of patients. As in most countries, in England, we've seen a huge increase in opioid prescribing for chronic pain in the last 2 decades. There is therefore, there's only just been flattening of that curve in the last couple of years. So this means there's a cohort of patients who are now stuck on high-dose long-term opioids that is probably giving them no benefit for their pain, but is exposing them to all their increased risks. So there are these patients who will be presenting for surgery established on these drugs, and we know that they're going to have a much more turbulent post-operative course. Their pain after surgery will be much harder to treat because they're going to be opioid tolerant, and there's increasing evidence of poorer outcomes after surgery, possibly related to opioid-related immunosuppression and endocrinopathies. Chronic pain also brings with it anxiety, depression, and poor sleep, providing a really toxic mix which spirals their patient's quality of life downwards, so that actually living with chronic pain is a pretty miserable thing to do. So as well as using drugs for that, we also encourage patients to improve their quality of life by using physiotherapy and exercise, and also by using psychological techniques to address these cofactors of pain and learn to live with the pain, but have a better quality of life. But what's very, very clear is that opioids are neither safe nor effective for the majority of patients with chronic pain. So we need to keep opioids for where they work best, as part of multimodal analgesia to treat acute postoperative pain. We need to keep patients safe by monitoring them for adverse effects, and we need to educate them so that they understand how to wean opioids once their acute pain settles. And we'll be hearing more about this in the rest of this webinar. Thank you very much.
Excellent. Thank you, Jane, for an excellent talk. The bar is being set extremely high, but I'm very confident that our other speakers will be up to the challenge. Can I just remind people, at the bottom of your screen, there's a Q&A button there. If you have any questions, please do put them in and we will do our best to address those. So our next speaker is Dr. Nicholas Levy, who's a consultant in acute pain and perioperative medicine in West Suffolk Hospital in the UK. Nicholas has been an absolute driving force, at first nationally, but later internationally, to highlight issues with good opioid stewardship. And it's a great pleasure to introduce him for his talk now.
Good afternoon, and thank you for that introduction, and thank you for inviting me to speak today. So here are my declaration of interests. Over the next 10 minutes, I would like to discuss the impact of opioid-related adverse drug events on patient outcome. This will enable me to discuss the rationale for guidance on perioperative opioid stewardship. I will also share with you the results of the survey on opioid stewardship that we undertook at the ERAS meeting in Sweden in 2018, which directly led to the creation of the International Consensus Statement. I will then briefly discuss the methodology for the International Consensus Statement. I will also highlight the other available guidance on the prevention of harm from postoperative opioid use. Penultimately, I will discuss the limitations of the guidelines and then ultimately the necessary next steps. In this retrospective study involving 140,000 patients recruited from 21 hospitals in the US, 10% of patients experienced at least one opioid-related adverse drug event, and these adverse drug events range from constipation to acute respiratory failure. Not unsurprisingly, these adverse drug events were associated with increased healthcare costs, increased length of stay, as well as increased risk of death. Thus, we can see that preventing opioid-related adverse drug events is beneficial to patients, family and friends, as well as the wider healthcare economy. Continuation of opioids on discharge can also lead to additional opioid-related adverse drug events. These include persistent postoperative opioid use, which is also known as PPOU, opioid-induced ventilatory impairment, which is also known as OIVI, opioid diversion, and drug driving. We now know that in the US, the incidence of persistent postoperative opioid use is as high as 26% in previously opioid-naive patients, and up to 77% in people with previous opioid exposure. And persistent postoperative opioid use is now the most common complication of surgery in the US. We also have evidence that surgery is a risk factor for persistent postoperative opioid use in the UK too. So persistent postoperative opioid use is not just a US issue, but is now a worldwide crisis. As well as the social harms of persistent postoperative opioid use, opioids can lead to opioid-induced ventilatory impairment. This results in death or hypoxic brain injury. It must be emphasized that nearly all deaths attributed to opioid overdose are caused by opioid-induced ventilatory impairment. So we tend to refer to the respiratory depression caused by opioids as opioid-induced ventilatory impairment, or OIVI. This is because opioid-induced ventilatory impairment is actually caused by a triad of factors, of which depression of the respiratory center is only one component. There is also the reduced tone of the supraglottic muscles causing airway obstruction. And there is the reduced levels of consciousness and wakefulness caused by the central action of opioids on the orexin arousal center in the hypothalamus. Opioid misuse and opioid diversion is another major complication of postoperative opioid prescribing. Excess supply of opioids and poorly stored opioids can become a pool for others in the community to abuse. It is estimated that approximately 2 million people per year misuse opioids in the US, and that 5% of the UK population now misuse opioids. Drug driving is yet another repercussion of postoperative opioid prescribing. There is evidence to demonstrate that there is an increased risk of fatal road traffic collisions within 30 days of commencing opioids, and patients need to be warned to avoid drug driving for both their safety and the safety of other road users. So, in 2018, at the ERAS conference, we surveyed the delegates and we achieved a 35% response rate. We asked 7 questions surrounding postoperative opioid stewardship. These are some of the questions we asked. As you can see, the overwhelming response was that the principles of opioid stewardship had not yet been adopted in the institutions of the delegates. Thus, we realized that perioperative clinicians were unwittingly contributing to the global opioid healthcare crisis. We decided to rectify this and create international guidance. We recruited further perioperative healthcare professionals from around the globe, including pharmacists, addiction specialists, primary care doctors, and nurses. The 16 of us then undertook a systematic literature review with the goal of identifying the risk factors and the remedying factors for persistent postoperative opioid use, opioid-induced ventilatory impairment, opioid misuse and opioid diversion, and driving under the influence of opioids. Having identified the risk factors, we identified approximately 60 remedying recommendations to reduce the risk of these 4 conditions. These recommendations were then subjected to a 3-round Delphi process to create the top 10 recommendations, many of which Professor Macintyre will discuss in her talk, and are also highlighted on the slide here. Obviously, there are other guidelines out there, but I may be biased, but I think there are certain advantages to the guidelines that was created by us and project managed by Prof. Lobo. These include the fact that these guidelines are international and multidisciplinary, and thus apply across the globe. Also, all the authors recognize that opioids are required to allow complex surgery. And whilst opioid-free anesthesia is possible, opioid-free analgesia is not. Therefore, effective opioid stewardship strategies are necessary. Also, the format is very reader-orientated, and Prof. Macintyre will share some figures with you that exemplify its readability. These guidelines discuss the importance of reducing harms from OIVI, opioid-induced ventilatory impairment, drug driving, and opioid diversion, in addition to persistent postoperative opioid use, which is the center and the focus of most of the other international guidance. Obviously, there are limitations to our guidelines. These include the fact that the recommendations are not graded and that there were no representatives from either Africa or Canada. Moreover, guidelines are only part of the solution to implementing change, and there is a need for high leverage local and national strategies to really implement change. I will now leave you in the capable hands of Prof. Macintyre, who will discuss with you the strategies to mitigate harm from opioids.
Thank you, Nicholas. That was fantastic as usual. I think it's been a very clear exposition of the driving force behind the guidelines and what the guidelines say. It's now my pleasure to introduce Professor Pamela Macintyre, who's professor in the Department of Anesthesia, Pain and Hyperbaric Medicine at the Royal Adelaide Hospital and University of Adelaide in Australia. Pamela has been a great force behind trying to reduce opioid-induced harm, and the main areas of her research include persistent postoperative opioid use and opioid-induced ventilatory impairment. So Pamela is going to talk to us now on the mitigation of harm from opioids.
Thank you, and thank you for asking me to talk. Nicholas, in the talk he's just given, has outlined 4 of the key harms that can arise from opioids when they're given to patients for management of their postoperative pain. These were persistent postoperative opioid use, or PPOU, opioid-induced ventilatory impairment, or OIVI, opioid misuse and diversion, and finally, drug driving. What I want to do in terms of trying to mitigate harm from opioids is look at some of the ways we can do this. And largely, it relies on identification of potential risk factors. These risk factors could be fixed or modifiable. Now, the fixed risk factors are usually patient-related, and they're often things we can do nothing about. For example, we can't make an old patient younger again, nice as that would be. So we need to concentrate on modifiable risk factors, because once we've identified those, they can be avoided wherever possible. In the paper that Nicholas mentioned, the International Consensus Guidelines, of which all speakers in this session were authors, we put together two tables for PPOU and OIVI, the two harms with the highest number of identified modifiable risk factors. And what I want to do now is look at just some of these factors, ranging from pre-admission to post-discharge. In the tables, we've listed the risk factors. We've also put recommendations and included some of the rationale behind those recommendations. So starting first with PPOU, one of the big risk factors is preoperative opioid use. And I don't mean opioids just 2 or 3 days before surgery. This is long-term opioid use for months prior to patient admission. We know that long-term opioid use is probably one of the most significant risk factors for PPOU. Not only is the patient's usual opioids continued, but we know that the use of any additional opioids that have been prescribed for their acute pain are likely to be taken for much longer than opioid-naive patients after discharge. There's also a dose response to this. The higher the preoperative dose, the greater the risk. Therefore, the recommendation for this section was that opioids should be weaned or tapered before the patient has their operation. Now, this is obviously easier said than done. It needs to start months before surgery, not the few days or few weeks when the patient is seen in the pre-assessment clinic. It can't be rapid or forced, and it does need to have the patient willing to be involved. The process needs to be patient-centered. A lot of patients will quite rightly be quite concerned that if their opioid doses are reduced, they will have a flare-up of their chronic non-cancer pain. I think we can reassure them by saying that the current evidence suggests that tapering of opioids in the majority of patients, most of the time, doesn't actually lead to a flare-up of pain. It either reduces their pain or the pain remains unchanged. But in most cases, the patients are not worse off. The next modifiable risk factor that I want to talk about is unrealistic patient expectations, or patient and carer expectations. Prior to surgery is the best time, prior to admission, to set realistic expectations. We need to explain to the patients that both in hospital and after discharge, some pain is to be expected. Zero pain is not our aim. Our aim is to restore good functional activity, such as mobility, deep breathing and coughing, rather than reducing pain scores to zero. We can talk to them about the risks and side effects of opioids, and most importantly, I think, this is the time to start the conversation about opioid use after discharge. And if they are sent home with some opioids, the aim of such treatment is short-term only, with progressive reduction in dose and then cessation of that opioid, all within a relatively short time frame. The next modifiable risk factor I want to look at is reliance on unidimensional pain scores. We know that they're commonly used in many, if not most, hospitals to assess patients' pain. Of concern, though, is that sometimes they are used by doctors and nurses to determine when a patient needs more opioid, or if that opioid dose needs to be increased. We know now that chasing pain scores, particularly down to a predefined level, such as pain scores of less than 4 out of 10, isn't safe. And it doesn't just increase the risk of prolonged use of opioids after discharge, but it also increases the risk of OIVI, which I will come to again later. So the recommendations are that pain scores alone shouldn't be used to guide pain management, and that some assessment of function should be added. This is a very simple functional activity scale that we've used for the last decade or so, just A, B, or C, depending on the ability of the patient to complete their activity, relevant activity. So a patient with a FAS of A, for example, has no limitation of relevant activity due to pain. And even if their pain scores appear to be on the high side, it doesn't mean they need more opioid at this stage, and it doesn't mean they need an increase in opioid dose. Long-acting opioids are also a modifiable risk factor for PPOU. And by long-acting, I mean modified release oral opioids, and they're also called controlled release, slow release, sustained release, and also transdermal opioid patches. Fentanyl patches in particular are specifically contraindicated for use in acute pain and postoperative pain management in many countries because of their very high risks. We know that when long-acting opioids are initiated for management of acute pain, there is a higher risk of long-term opioid use. And it's not even as if long-acting opioids are going to provide better pain relief than immediate release opioids. There was a publication late last year that showed when acute pain was managed with modified release opioids compared with immediate release, the patients given the MR opioids actually had higher opioid requirements and higher pain scores, both at rest and movement. So long-term opioids are not just unsafe, they're not more effective. There is therefore no reason to use them, and recommendation is made to use immediate release opioids given on a PRN as needed basis only. This recommendation is clearly in line with a number of guidelines that have been issued by professional bodies, regulatory bodies in many countries. The final two modifiable risk factors I want to look at for PPOU are the characteristics of the opioid prescription, long duration of discharge opioid prescription, and repeat prescriptions. This study used a random sample of patients from a very large database where they looked at the information obtained from just over 1.3 million opioid naive patients aged 18 years or older. Not all of these patients were commenced on an opioid for acute or postoperative pain. Some had pain for other reasons, but nevertheless, the results of the study are very interesting. You can see from this graph on the left hand, on the vertical axis, is the probability of continuing opioid use, both at 1 year and 3 years after commencement. And you can see quite on the horizontal axis, is the number of days supply of the first opioid prescription. That is the number of days that the first initial opioid prescription is designed to cover. You can see quite clearly, the greater the number of days supply, the higher the risk of long-term opioid use. So the recommendation in the acute pain setting is that the number of days covered by the first prescription should be limited, typically to less than 7 days. Many guidelines from various countries are suggesting 3 to 5 days before the patient is assessed. The SHOWER study also showed that repeat prescriptions are at risk, that is, repeat prescriptions given for that episode of opioid use. On the vertical axis, the probability of continued use is unchanged. On the horizontal axis, shows now the number of prescriptions in that first episode of care. And again, there is a significant correlation between the number of repeat prescriptions and the risks of prolonged opioid use. So the recommendation in the acute pain setting, particularly after discharge, is that opioid prescriptions are not repeated automatically, that before another prescription is given, the patient needs to be assessed. And that's just proper patient care. If the patient has ongoing pain, we need to know why. Turning now to OIVI and the first two modifiable risk factors that I want to cover, initiation of long-acting opioids and co-administration of sedatives. Simply put, long-acting opioids increase the risk of OIVI. So that the recommendation as for PPOU is that immediate release opioids titrated on an as-needed basis only should be used. When it comes to sedatives, I think most of us are aware of the risks of combining opioids and benzodiazepines. Whether or not the patient is in the hospital in the community, this combination markedly increases the risk of OIVI. What is less well understood, or certainly has been less well understood until recently, is that the combination of gabapentinoids and opioids is equally dangerous. Gabapentinoids have certainly formed a very common part of postoperative pain management protocols, including ERAS protocols. But we know now that people are pulling back on those recommendations. And when I looked at the ERAS Society guidelines, I could see that gabapentinoids are no longer recommended for patients having total hip and knee arthroplasty. And for colorectal surgery, only a single small dose preoperatively is recommended. So the recommendations for higher doses and for repeat doses after surgery aren't there. The recommendation is easy. Where possible, the combination of opioids and sedatives needs to be avoided. As with PPOU, reliance on unidimensional pain scores alone is also a risk factor for OIVI. Chasing pain scores is not appropriate, and they shouldn't be used as the sole means of determining adequacy of analgesia. This was very nicely shown in a study by Wheeler et al. Over 15 years ago now. In a cancer center, they introduced a numerical pain treatment algorithm for treatment of acute pain, largely prompted by the now discredited Pain as the Fifth Vital Sign campaign, and also to comply with accreditation, hospital accreditation requirements at the time. With this algorithm, patients who had pain scores of 4 or more were given an opioid. Patient satisfaction was significantly improved. The problem is that the incidence of OIVI doubled. So this clearly showed that reliance on pain scores alone for opioid titration are not safe. The other risk is inadequate monitoring of patients to determine whether they're developing OIVI or not, and also the lack of the appropriate response, the triggering of the appropriate response to a patient who is developing OIVI. The Wheeler study again showed this in a total of 29 patients. So this was 29 patients before and after the intervention who developed OIVI. Only 3 of them, only 3 out of 29 were noted to have a respiratory rate of less than 12 breaths per minute. But 27 of them, so all but 2 patients, were documented in their charts to have increasing sedation prior to the OIVI event. So the recommendations that result from that are level of sedation. A patient's level of sedation should be assessed routinely and regularly because it's a more reliable indicator of developing OIVI than respiratory rate. And there also need to be appropriate instructions that can be followed should a patient become excessively sedated. Many sedation score systems are available. This is one we use, and it's commonly used throughout the countries. What we're aiming to do, firstly, sedation score 2 is taken to indicate early OIVI, and what we're aiming to do is titrate opioids so that a patient's sedation score is always less than 2. And finally, I just want to make a few comments about the last 2 key harms that can arise: opioid misuse, diversion, and drug driving. We know now there are many, many papers that have shown that the discharge prescription for opioids for ongoing acute pain management when patients leave hospital are often not appropriate, either in terms of expected pain severity or expected duration of pain that patient is likely to have after surgery. And as a result, the publications have shown that there are often very, very large amounts of unused opioid remaining. These pose a further risk to the patient should they choose to use them for reasons, other reasons later on down the line, but they are also known to pose a risk to family, friends, and even pets, especially when opioids are stored unsecurely, as they often appear to be. And if those opioids leak out into the community, if there is some diversion, these excess opioids then pose a risk to others in the community. It's interesting to note that over 50% of patients or people who misuse opioids actually source them from family or friends. So we need to make sure that we're not aiding and abetting in providing that source when patients leave hospital. The recommendations are pretty straightforward. The number of tablets dispensed should be limited. The number of tablets prescribed should be based on the number of tablets the patient required in the 24 hours prior to discharge. And we absolutely need to tell patients about safe storage, safe disposal of any unused opioid, and warn them they shouldn't give opioids to others. The final harm that I just want to briefly touch upon, because Nicholas has already said drug driving, driving under the influence of opioids is already recognised as a major risk factor for motor vehicle crashes, especially within the first days after starting that opioid. In many countries, it may be illegal to drive if impaired by opioids or if drug levels exceed certain predetermined limits. The recommendation is therefore to advise patients of the dangers of driving while they're taking their opioids, and also the potential legal requirements. And for acute pain, the opioids that patients are sent home with after discharge, they shouldn't be driving until all the opioid has been ceased. So in conclusion, opioids are still an important component of postoperative pain relief, and they're likely to be so for some time yet. We need to realise that there are risks of significant harms, but also that there are reasonably easy ways in which we can mitigate that harm. The key is recognising and avoiding modifiable risk factors where at all possible. Thank you.
Thank you, Pam, for an excellent overview, as always. Our next speaker is our penultimate speaker, and it's Felicia Cox, who is lead nurse and head of pain services at the Royal Brompton and Harefield Hospitals in the UK. She's a co-editor of the British Journal of Pain, and appropriately, she is leading an international co-produced patient information project concerning reducing harm with post-operative opioids. So Felicia, over to you, and thanks for giving up your time.
Welcome. My name is Felicia Cox, and I'll be speaking about the nursing contribution to preventing harm with opioids in the perioperative period. Nurses don't work alone. We don't work in silos. We are codependent with our colleagues who work in surgery, anaesthesia, pain medicine, physiotherapy, occupational therapy, psychology, and also pharmacy. In 2019, the European Federation of IS chapters published a core curriculum for highly specialist pain nurses working across Europe. This can lead to a diploma in pain management nursing. What do we do in our daily practice? Well, we educate not only patients and carers, but also the multidisciplinary team, both formally and at the bedside. We develop and implement policies and guidelines based upon best available evidence. We regularly undertake audit and quality improvement projects, striving to improve not only patient outcomes, but also ensure safe care. We're also responsible for ensuring that nurses at the bedside undertake regular assessment of pain, together with any side effects related to their surgery or to the analgesic medicines that they're receiving. We're certainly moving away from solely numerical pain rating towards functional pain assessment. And during this entire time, we're preparing our patients and their carers for the point of discharge. Recognition of the potential for harm begins in the pre-assessment phase. Nursing pre-assessment identifies patients with airway issues, including sleep apnea, those taking high-dose opioids and concurrent sedative medicines. Opioids may be reduced if time allows, and a multimodal analgesia plan will be discussed and agreed with the anaesthetist and also the patient, as well as the pain team. Expectation setting should begin at this stage. Preparation for admission should also cover reasonable adjustments, with a management plan covering the use of non-verbal pain assessment tools, for example, for a patient who's got a learning disability. Patients may benefit also from prehabilitation, and planning for discharge should also begin at this point. Now we come to where. The Nightingale Ward offered nurses and other patients a very clear view of all activities and aided early recognition of the deteriorating patient. But one of the prices we paid, however, was a lack of privacy. Recently, centralised nursing stations have been employed to aid nursing care and also to contribute to infection prevention strategies. In inpatient pain, we're embedding function as a key component of pain assessments. Patients often struggle with unidimensional pain scores, such as using a 0 to 10 scale. Thus, the ability to perform key tasks, such as deep breathing, coughing, and expectorating sputum after thoracotomy, should be the driver for additional analgesia, not a self-reported numerical rating of pain intensity. The frequency of observations for a patient receiving opioids must be individualised, and local policy must mandate this, whether it's hourly or second hourly, after additional opioid administration. Opioid-induced ventilatory impairment will have been covered earlier by Professor Macintyre, but we're very interested in sedation scoring. A lot of centres are using early warning scores, but the level of consciousness is not sensitive enough for us to pick up opioid-induced ventilatory impairment. A score of 2 or more should be taken as early indications of opioid-induced ventilatory impairment, and we should be titrating analgesia and ensuring that the sedation score always stays below 2. Preparation for discharge, as I mentioned, begins at pre-assessment. We should be educating patients about how to limit doses and then to reduce the dose and then the frequency. We also need to limit the duration of tablets that we're sending patients home with to reduce the risk of diversion and also to aid disposal. We also need to provide our colleagues in primary care, such as general practitioners, with clarity regarding the need or not for repeat prescriptions. And this is really key. Our communication is key. Thank you for listening.
Thank you, Felicia, for highlighting the role of the nurse specialist in the management of postoperative pain. We now move on to our last speaker, who's Ed Mariano, who's professor in the Department of Anesthesiology, Perioperative Medicine and Pain Medicine at Stanford University School of Medicine. Ed's going to talk to us about the role of regional analgesia in reducing perioperative pain.
It's a pleasure to join you today. I'll be talking about the role of regional analgesia in reducing postoperative opioid use. My name is Ed Mariano again, and I'm a professor at Stanford University School of Medicine. So I think when you talk to any regional anesthesia enthusiast, we'll always say that we have a block for that. Yeah, we all love regional anesthesia, and I think we believe that regional anesthesia makes a big difference for patients in terms of recovery. And I think we know why. We know what regional analgesia does. We know it can decrease the maximal pain intensity that patients feel after surgery. And we know that regional analgesia, when properly managed, can be titratable. It also decreases short-term opioid consumption, which has been shown in numerous studies, especially in the inpatient realm for major surgery and even in the outpatient realm for outpatient surgery. And we think that the less exposure that patients have to this acute postoperative pain can actually decrease, perhaps, opioid-induced hyperalgesia. We know that getting people moving is so important in terms of enhanced recovery protocols, and avoiding immobility, immobility being a known risk factor that can produce hyperalgesia and persistent pain, is critical, especially if we want to make sure that patients have the best possible long-term outcomes afterwards. However, regional analgesia, as it is currently practiced today, still has limitations. And this is an interesting study that I performed with some of our colleagues at Stanford University Department of Anesthesiology, where we looked at the Truven Market Scan database. And these are relatively younger patients. This is not a Medicare population for us, which is 65 or older, but a younger population of patients who have total knee arthroplasty. And when we looked at these data, we did not find an association between the use of nerve blockade as it is currently practiced and the risk of chronic postoperative opioid use. And if you look at the breakdown of patients who are opioid naive, those patients who were taking intermittent opioids before surgery, and even those who have been chronically on opioids, you can see that there is no statistically significant difference between these patients in terms of long-term opioid use after their knee arthroplasty. And I say that there are multiple caveats because regional analgesia, the way it's practiced today, is very limited. And that being said, regional analgesia in general is still underutilized, even for very common surgeries, which many of us who are very enthusiastic believers and scientists in regional anesthesia would love to change. But as it is right now, not every patient has access to regional analgesia. And so when we look at pain management after surgery, it is critical that we think about a multimodal approach. This means that we're not basing our postoperative pain management solely on one category of analgesia. And regional analgesia is really just one row in this table that contains many different classes of analgesic agents, from non-pharmacologic agents to systemic non-opioid analgesics. And even opioids are still considered a very effective means for analgesia for specific indications after surgery. What I think is important when we think about multimodal analgesia is that oftentimes we consider regional analgesia as an option. However, I think it's important that we look at pain management as really a game of marginal gains. And so even when you look at protocols that are fairly robust, and this is an editorial that I wrote with Dr. Jody Lang, who works with me, even in an institution like Rush University, where they have what we consider a business class multimodal analgesic regimen. They already had local infiltration by the surgeons. They already had dexamethasone, ketamine, acetaminophen. They had scheduled and PRN opioids. Even in a system like that, for gastric surgery, the addition of a local anesthetic, a regional block, a TAP block in those patients still led to 9 and 11% improvement in 2 different types of gastric surgery. And so this is the example of marginal gains that I mentioned, because regional analgesia can still offer benefits on top of multimodal analgesia. We just have to make sure that more patients have access to it, and we teach more anesthetists to develop the skills involved to provide regular regional analgesia on a consistent basis. When we think about how we manage pain, and I alluded to this earlier when I talked about how regional analgesia as it is currently practiced does not have long-term benefits in chronic opioid use, it's because we don't currently understand exactly how long pain lasts. And I think we know that there are different trajectories for different types of surgery. And this is a compilation graph that we wrote as part of an editorial piece for the journal Anesthesia. And if you scan the QR code with a second device, it'll take you directly to that article. And we know from different types of surgery, this is in one population of patients at one university hospital, but you can see there are different trajectories based on the type of surgery, from outpatient shoulder arthroscopy to knee arthroplasty to mastectomy to hip arthroplasty. The pain trajectory is different for all of these surgeries. And so the way we treat pain for these different surgeries has to be different. And if you look specifically at knee arthroplasty, I think this is a very important subpopulation of surgical patients. You can see that even in the patients who do not develop chronic pain, they can have mild to moderate pain for about a week. And those patients who go on to have chronic pain will have moderate pain for more than a week. And then a subpopulation of those patients who develop chronic pain will have neuropathic pain, and their pain actually increases towards the end of 1 week. And I think it's important for us to think about this in terms of the way we develop our techniques related to regional analgesia. Now, we know we have one means of continuous peripheral nerve blockade that can extend the duration of regional analgesia. It is also the only means of extended duration regional analgesia that is currently titratable and still acts pharmacologically to block nerve transmission. We know that those types of blocks, those advanced regional analgesia procedures, are still currently not widely practiced. And there are many factors, some of which are system related. So I think it's important when we discuss the institution of multimodal analgesic protocols within enhanced recovery, we try to keep it as simple as possible. And this is just a figure, the QR code will take you directly to the link, and it just shows the different ways that we can attack pain. And similarly, this is actually a graphic that I use to explain multimodal analgesia to my patients, because I think it's important for them to understand that we are attacking pain at multiple sites, so that way we can improve their recovery and facilitate their mobility from surgery. If we look at pain more as a continuum, and I think this is really critical, is ideally we would identify those patients with higher risk for greater than expected acute pain before they even come to the operating room. And then we can implement our in-hospital enhanced recovery protocols, which integrate multimodal analgesia. But I think what's really critical if we want to make a big difference in terms of opioid use in the long term, we have to look at the post-discharge recovery for those patients from the time that they leave the hospital until they fully convalesce from surgery. And this is a big area for improvement. And it's also a big opportunity for us in terms of acute and perioperative pain management. One intervention that we've implemented, and this is going beyond regional analgesia, but I think this realm of regional analgesia and perioperative pain management really blend together. But this is actually a patient-specific opioid tapering protocol we instituted at our hospital more than 2 years ago, which has actually decreased post-operative opioid use for all of our total joint replacement patients and also our spine surgery patients now by 2/3 over the course of 6 weeks after surgery. And this did not result in an increased rate of refills. It didn't increase the emergency department visits or readmissions related to pain. I think that this is the kind of intervention that we as anesthetists who are interested in perioperative pain management and patient recovery have to get involved in if we want to make a big difference. And it takes a culture change at your hospital. The other innovations in regional analgesia that may aid opioid tapering and may make a difference in the longer term, although it's yet to be proven, are interventions that last longer. As I mentioned, local anesthetic infusions, even with continuous catheters, have limited duration. However, when we look at other interventions like neuromodulation of the peripheral nerves or even cryoanalgesia, now you're looking at interventions that are still targeted because they still attack specific nerves, but they can last for several weeks. And these interventions may have longer lasting benefits, especially if we start to factor in trajectory modeling for postoperative pain, especially considering those patients who have longer trajectories of pain resolution. And then finally, besides some of the technical aspects, we have to look at better ways to develop a service. And so that gap between post-discharge and full convalescence as an outpatient really needs to be filled. And as anesthetists, we have the skill set to develop these transitional pain services modeled after our colleagues at the Toronto General Hospital under the leadership of Dr. Hans Clark. And we've set up a service like this at our hospital as well. And this takes into account those complex patients, patients with substance use disorder, patients with chronic opioid use or chronic pain. We have preoperative evaluation and preparation for surgery, as well as postoperative convalescence and follow-up even after the patient leaves the hospital, to ensure that those patients have not only ceased to take opioids, but we can even adapt their tapers and also ensure that they have pain management in case they start to declare themselves as chronic pain patients. This is the kind of work that we as regional anesthesiologists, as perioperative physicians, have to get into if we want to make a difference in terms of patients' long-term outcomes. Thank you so much for your attention.
Ed, thank you for an excellent talk, and indeed thank you to all of our speakers for an outstanding contribution. The time is about 4 minutes past the hour, so we've got about 25 minutes or so for a discussion with the panel, and not only are we being joined by all of the speakers, but on top of that, it's a great pleasure to ask Dr. Hans de Beer, who's an anesthesiologist and pain specialist in Groningen, the Netherlands, and Professor Gregg Nelson, who is chief of gynae oncology surgery at the Tom Baker Institute in Alberta, Canada. So I can see lots of smiling, happy faces on the screen, which is always a good start. And I'm now going to hand over to my co-chair, Dileep, to ask the first question.
Thank you, Bill. I've got a question for you, Jane. It may be a bit difficult to answer, but is it possible to differentiate between the physical and psychological contributors to postoperative pain?
I think that's a good question. I think postoperative pain, we'd expect everybody to get postoperative pain. I think people react very differently to that pain, and that fits completely with these emotional pathways, so that people will respond very differently based on their baseline anxiety, depression, on their previous pain experiences. And I think the really important thing to do is to make sure that you're optimizing multimodal analgesia to treat the physiology of pain. And if you do have somebody who is very distressed with the pain, rather than pile on lots of opioid to try and treat this pain, it's really useful to sit the patient down and actually talk to them and ask them what they think is happening and what they're scared of and what they think we can do to make things better. So address their psychology rather than just carry on piling in more drugs, particularly more opioids, that just won't help them particularly, but will put them at increased harm.
Thank you, Jane. There's another question for you from Adil Siddiqui, who asks if there's any merit in using a combination of morphine and tramadol to treat acute pain.
Yeah, no, I think so. And I think by By using regular weak opioids, we can then opioid spare on the strong opioids. So we commonly use regular tramadol or regular codeine or dihydrocodeine, and then keep the strong opioids such as morphine or oxycodone as PRN to enhance function. And I think that can be very effective.
Okay. Thank you. So there's a question here from Charbel El Kafui. I hope I pronounced your name right. It's about the role of cannabis and non-pharmacological agents, e.g. mediation, cold, warm, etc. I'm going to direct that both to Nicholas Levy and to Felicia. So take it in turns if you don't mind.
From what I'm aware, the role of cannabis in the management of acute surgical pain is very limited, and the evidence to support its use hasn't yet been found, even though lots of people are trying to find its role. But other people might know more about that than me.
Okay, Felicia, let's see if you know more about it.
I certainly do. I sit on the Council of the British Pain Society. There's been lots of talk about the use of cannabinoids. Increasingly, patients are coming with persistent post-surgical pain and also chronic pain from a variety of different causes, attending clinics for persistent pain, already taking some form of cannabis. The problem is that there's no regulation with regards to the amount of THC in these formulations, and also there's a lot of illegal use. At present, there is the jury is out. There is no strong evidence that suggests that there is improved function or decreased pain associated with cannabinoids. Thank you.
Okay, thank you. So I'll just ask one more and I'll hand over to Dileep. We're fortunate to have two gynae oncology surgeons here. So I'm going to ask them to comment on a question about post-discharge medication and the role of the surgeon, who is often making the opioid at discharge. How do they interface with the clinical pharmacist in your institutions? Would you like to kick off?
Yeah, maybe I can start. Thanks for the question. I think that's, it's a really important part of sort of the post-operative pain program. I think there's lots of situations where, teams may give appropriate scheduled preoperative medications. The anesthesiologist does a great job intraoperatively. There's great care that's taken, in the post-operative inpatient period, where, there's a focus on non-narcotic or at least opioid sparing. But then for some reason, there's just a gut reaction at discharge to provide, 30 of Percocet or, 30 of acetaminophen and codeine without even giving any attention to, in fact, did the patient even require any narcotic in the last, 24 to 48 hours prior to discharge. And so certainly in Canada, there has been increasing attention being paid specifically to the 24 hours prior to discharge to determine exactly, how much narcotic does that patient really need. I am a really strong proponent of looking at that. And obviously, as you say, Bill, incorporation of the clinical pharmacist certainly on our unit has helped with that. I still find residents and trainees who are, trying to be helpful. And even at the time of the operation the other day, I caught one of our trainees writing a prescription for 30 of Percocet that they put on the chart even before the operation was done. So, this is something where, trainees are trying to do the right thing, what they think, but I pulled them aside to say, that's really the wrong approach. So I think others have actually, there's some evidence-based tiered opioid prescription guidelines. I think that's a bit of a good segue for my colleague, Sean, who has done some work in that area. So I'll pass it over to him.
Yeah, thank you. Good morning. Nice to see everybody. I think Gregg hit the nail on the head, and that probably the most important thing is just to be thoughtful about writing these prescriptions at discharge. So I think for a long time, we've just been so used to writing the same thing for everybody, whether it's 30 or 50 or even more than that for some orthopedic surgery dismissals, for instance. We did quite a bit of work in this a couple of years ago and found that patients really need very little pain medication at discharge. We also looked at their habits of how much pills they used after discharge, and about 30% of patients use nothing. And this is the most invasive procedures we do in gynecologic oncology, 4-quadrant cytoreductions for ovarian cancer, a big laparotomy. 30% don't use anything in the hospital. So at least that many don't use anything when they go home. And when they do use opioids, just about everybody's stopped using them at 7 days. So in terms of interacting with the pharmacist, probably the most common thing we do is when we have patients who can't take non-steroidal anti-inflammatory drugs, we really talk with the pharmacist to understand if that's necessary or not, if we do need to withhold that, because that makes a big difference in how many opioids are required post-operatively.
Thank you, Sean. I've got a question for Pam now. Pam, is there a difference between PPOU and addiction? Or is addiction only part of the spectrum of PPOU?
I think it's more than that. Addiction is really part of the spectrum of opioid misuse, and which can vary from just using it, the term, and I can't remember his name, chemical coping, where people use opioids just because it makes them more able to deal with the stresses of everyday life, right down to misuse for addiction. So I think if you give someone who has that tendency too many opioids, you might be fueling that. But I don't think you can say prolonged post-operative use is addiction.
Okay, thank you. Over to you, Bill.
Thank you. I have a question here. Excuse me. I have a question concerning the concept of opioid-free analgesia and its role in reducing post-operative opioids. What I'd like to do, because he's looking very comfortable and hasn't answered a question too recently, is direct that to Ed, and maybe also ask Hans de Beer to comment as well as a pain specialist. So Ed, please.
No, thank you so much. I think it's a timely topic. I think what we've seen around the world, but very focused in North America, have been really a game of extremes. And so we've seen over opioid prescribing on one extreme, and then the complete avoidance of opioids on the other extreme. I think that more recently, we've seen publications that have really advised toward a more moderate approach for the use of opioids in the perioperative period. I mean, this is a class of analgesic drugs with proven efficacy that has been around for thousands of years. And I think as anesthetists, part of our training is really understanding the benefits and risks and proper indications for every drug class. So I think that the evidence, as we have it currently available, does not show that strictly avoiding opioids within the theater walls from the time that the patient enters until they leave the theater makes any difference in terms of postoperative opioid use in the short or long term. And it's not surprising, because even if you avoid opioids within the theater, and then the patient receives opioids in recovery, and then receives opioids on the ward, and then gets the same standard prescription for 90 pills of oxycodone when they leave the hospital, then clearly that hasn't changed persistent opioid use. And I think that we have now a very recent study just published this month in anesthesiology that actually shows the results of a clinical trial that was stopped early that actually showed that the opioid-free protocol led to more postoperative complications. And that's not surprising either. I think that the replacement for opioids, especially when they are given as indicated, usually leads to a lot of arbitrary polypharmacy.
Yeah, thank you. So Hans, please, thank you.
Yeah, so a few things I heard. It's very important to realize the role of the anesthesiologist to understand the processes induced by surgery and how to suppress the surgical stress to prevent the use of opioids perioperative, but also postoperative. And when focusing on this multimodal anesthesia strategy, that actually will reduce the post-operative use of opioids. And that can be done even with opiate-free anesthesia techniques. And I'm practicing for almost 8 years in colorectal surgery. I'm using no opioids whatsoever perioperative. So we have to make a clear definition for opiate-free anesthesia or opiate-free analgesia. And in the post-operative period, it's certainly not forbidden to use opioids, but when using opiate-free anesthesia, you can actually reduce opioids in the post-operative period. And there's evidence for it. And I like to comment on the recently published trial, the POFA trial, which was stopped earlier, which was recently published in Anesthesiology. Actually, that trial wasn't a good trial because it only compared remifentanil with dexmedetomidine. And we also accepted a letter in Anesthesiology, which will be published soon, that the POFA trial was actually not a good design because they had a lot of overdosing of dexmedetomidine. So please read the article of the POFA trial very well, and you can see that about 21% of the patients were violating the protocol.
Okay.
So,
yeah.
But I think opiate-free anesthesia is a very interesting research area. There are more data which show that post-operatively, when using opiate-free anesthesia, reduced opioids. However, there has to be an educational program because opiate-free is not just leaving out opioids, but it's another strategy. Actually, you have to learn to do another type of anesthesia.
Yeah. Okay.
I think that's really critical. I think you have to really enforce the multimodal approach to pain management, as Dr. de Boer really mentions. And I mean, I think that the definition of opioid-free really has to be clarified. I think because I think that there is this this notion that you can only restrict your intervention to this very brief time, but really it should be the continuum of the perioperative experience. You could take a look at an editorial that we wrote in the journal Anesthesia. We talk a little bit more about this issue of definitions, and just I think that it should be standard in anesthesia practice and perioperative care that we find ways to use multimodal opioid-sparing approaches.
Yeah, well, thank you both for tackling a subject that would really fill a whole webinar on its own, I think. My next question is going to put the blood pressure up of the two people to whom I'm going to ask it, which is Pam and Nicholas. It's about the use of long-acting opioids in orthopedic surgery. It is common, even in the institution that I work at, where a few days of twice daily long-acting opioids is used following, in particular, hip and knee replacements. How would you approach the problem of trying to reduce the use of modified release opioids? Who wishes to go first?
Nicholas, you go first then.
Yeah.
So I think that the issue is modified release opioids were introduced into surgical practice over a number of years, and mostly based on spurious evidence and spurious thought processes. And so eliminating them will take time. But I think if we go back and look at the evidence on how and why modified release opioids were introduced to surgical practice, we can understand that the evidence is poor. For example, some of the initial papers looked at the action of modified release opioids versus epidurals and PCAs in time to mobilization. And there's no doubt about it that an oral preparation that does not tether the patient to the bed space will allow mobilization. And if mobilization is the endpoint, that is completely understandable, because modified release were introduced at the end of the 1990s when we weren't using immediate release opioids like we now do. So I think that's quite telling. The evidence is not that great. Other evidence was created by Scott Rubin, and as we all know, he has been found guilty of fraud, so his papers can be brought into disrepute on this matter. We also are aware that actually it was Purdue that also sponsored a number of the papers perpetuating the belief that modified release opioids were essential. And we all know now, and especially as Sean demonstrated in his talk, that Purdue have been found guilty of widespread fraud in propagating the advantages of modified release opioids. And then if we look at the more recent evidence, and most of it does come from Australia, the use of opioids, modified release opioids, does not lead to increased pain control. It is associated with increased side effects. And so I think the issue is going to be getting people to recognize that these pseudo-axioms have caused a great deal of harm and need to be disproved. But I think the tide is turning. There are now a number of august organizations that have now outlawed the use of modified release opioids, whether it be the pain Faculty of Pain Medicine in the UK, the Australian New Zealand Association of Anaesthetists in the US, the FDA in the US, and so on. So I think the tide is turning, and I do think that in the next 5 years, modified release opioids will be removed from the armamentarium of the surgeon and the anaesthetist for elective surgery.
Excellent. So in the interest of time, I'm just going to ask Pam to briefly comment and then hand over to Dileep for the last few questions.
Just a couple of quick comments. Firstly, I have to put my hand up and say we never started using modified release opioids. I was concerned that they would be too much like a background basal infusion with PCA. And I spoke to the chair of our drug committee, and no one in the hospital was allowed to go down that route. The second concern I had, that people tend to use the same dose. And I noticed one person on the chat said 20 milligrams BD. I'm assuming that's slow release oxycodone. And that's for every patient. And yet we know as people get older, they need less opioid, and that patients in their 80s need about a quarter of the dose patients in their when they're 20. So I think the fixed dose is wrong. We did, however, there's another comment on chat that says 4-hourly PRN is often too long a gap. And back in 1994, we went to 2-hourly PRN, and then a few years later, we actually allow 1-hourly PRN on the basis that the peak effect will have been seen within an hour, and if the patient's still uncomfortable, they should get a bit more. So our nursing staff have been simply brilliant. We've been able to give PRN really quite well PRN. So A, we didn't go down the line. B, I think fixed dosing for every patient of every age can't be safe, but you do need to increase your PRN, decrease the PRN interval from 4-hourly.
Thank you.
Thanks, Pam. I think Ollie, who's the chairman of the ERAS Society, has a question that he wants to ask. So go ahead, Ollie. I think you're muted at the moment.
Yeah, well, thank you, all the speakers, for a fantastic program. It's a pleasure to have you with us today. So thank you all. I have a question. Is there a role for high-dose corticosteroids in reducing postoperative opioid use? I know Henrik Kellett has been propagating that for some time as a way of controlling pain.
In the BJA, a Canadian group has demonstrated that dexamethasone 6.6 milligrams is very effective. at reducing rebound pain after regional anesthesia. So I think there is a role, but the exact role, I think, still needs to be defined.
Thanks, Nicholas. We're coming to the end, so we've probably got time for one or two questions. So there's one that I'd like to ask Jane and Felicia. There's a lot of talk in the newspapers about drug companies now targeting low and middle income countries to sell their products that have been outlawed in the West. How are we going to prevent this? Because with the population in low and middle income countries, we could have a more serious opioid epidemic than they have in the United States.
Yes, if I can go first, I think this is disastrous and unethical, and it shows that places like Purdue Pharma and the Sackler family have learnt nothing. I think one of the huge problems globally is the disparity in opioid availability, and in our countries, the States and Canada, Australia and Europe, we have been hugely spoiled by very easy availability of opioids, and we've made a colossal mess of it. And there are lots of countries, very low in the lower income countries, where they struggle to get access to any opioids at all, even for patients dying of cancer. And unfortunately, what we have done has made those countries and their governments look to us and use us as a reason why actually they were right not to let opioids into their country. So we've not only ruined it for us, we've also accidentally ruined it for other people. So I think although it would be great to get opioids into these countries to give much better opportunities for pain management, both at the end of life and after surgery, I would like to think that we have to be very careful in how we do that. But given the fact that these huge pharmaceutical companies are going to be the ones doing it, I fear for any good practice, I'm afraid.
And I concur with Jane completely that there are lessons to be learnt from our experience, and certainly from marketing of these opioid medicines as almost harm-free some 20, 30 years ago. Thank you.
Thank you to our panelists, and we're out of time now. So I do apologize to all the members of the audience who've asked questions. We haven't been able to get to them. Now I hand over to Bill for the concluding remarks.
Thank you, Dileep, and thank you to all of our speakers and panelists. And on my screen in the top left-hand corner, appropriately, we have the chairman of the ERAS Society, Uli Lundqvist, as well. So just keeping an eye on things. So thank you all for an excellent session. Whilst you're all here, I just want to say that our next webinar will be on the 12th of June. And as you can see, it's co-chaired by Professor Gregg Nelson, who's here obviously, and Professor Nicholas Levy. And this will provide an introduction to the key steps required to implement ERAS at your institution. Further details will be available soon, but can I ask you all to pencil that date in? So on behalf of myself and Dileep, thank you very much indeed. I hope you've enjoyed it all as much as we all have. Thank you.